Hello, this is Dr. Grande and welcome to my video on the cognitive model. In cognitive behavioral therapy, we use the cognitive model to explain why clients have symptoms and eventually to explain how to correct those symptoms. So the cognitive model, as I'm going to describe it here, is largely from Beck, but also as I go through this model you'll see a lot of influence from Alice as well. So let's start with the structure of the cognitive model. There's several components to the cognitive model. The ones that I'm going to discuss the most are core beliefs, intermediate beliefs, and automatic thoughts. So now let's take a look at the first piece of the cognitive model. And as I move throughout this video, I'm going to build the actual model in these slides, one slide at a time. So you'll see it kind of progress as we move toward the full diagram of the cognitive model. So the first element is the top component of the model, which are the core beliefs. Now, the reason I emphasize the top component of the model is because the way I've constructed the diagram has core beliefs displayed at the top, but we usually think of core beliefs as something down deep. So it'd be, you could flip this model around, look at this as, core beliefs are down deep, and then we move up from there. But the way it's illustrated is core beliefs kind of start us off at the top of the model. So what are core beliefs? Well, core beliefs are these deeply held beliefs that everybody has. As you can imagine from the name, they're at the core, and we believe they're central to influencing human behavior. Most core beliefs are positive, and they're formed from our life experience. Typically, core beliefs start with the phrase, I am. For example, positive core beliefs that many people have would be like, I am competent, I am valuable, I am a good person. Even individuals that have depressive symptoms or anxiety symptoms still mostly have positive core beliefs. It's the negative core beliefs that are the area that we're going to focus on because we're trying to alleviate symptoms. And according to Beck, these negative core beliefs fall into three broad categories: the helpless core beliefs, the unlovable core beliefs, and the worthless core beliefs. Some examples from the helpless core beliefs would be, I am incompetent, I am needy, I am a failure, I am a loser. Examples of unlovable core beliefs would be, I am undesirable, unattractive, bound to be alone, different. And examples of the worthless core beliefs would be, I'm bad, I'm dangerous, I'm toxic, I don't deserve to live. Right? Clearly, as you listen to the sample of some of the core beliefs I selected from each category, the worthless core beliefs are the ones that typically as a clinician worry me the most, because when I hear statements like I don't deserve to live, or I'm toxic, or I'm unacceptable, I start worrying about suicidal ideation or any type of ideation related to self-harm. So let's move to the next level of the model. And you can see that from now how as the diagram is being built out, the next level is what's called intermediate beliefs. And these are attitudes, assumptions, and expectations that a client has. Now, Ellis would group core beliefs and intermediate beliefs together. Beck has them separated. So core beliefs, again, more at the core. Intermediate beliefs move a little bit more toward the surface. They are deeply held beliefs, they're often unarticulated, and we believe that in combination with situations, they create automatic thoughts. So let's talk about situations. So a situation is a stressor. Right? It's something that occurs in somebody's life that reacts with an intermediate belief. So let me use a concrete example, and I'll continue with this example through this video. Let's say that somebody has the core belief that they are unattractive and unlovable, right? And let's assume the client's a male and the client has a romantic interest in females. So the client has these deeply held beliefs, these core beliefs, right, that they're unlikable or unlovable, and probably unlikable as well, and unattractive. So the intermediate beliefs, which would be more, again, the attitudes, the expectations, the assumptions. The intermediate beliefs for a client like this might be that if they're in a situation, where there is a female to whom they're attracted, they're going to be rejected if they make any type of advance. So if they try to ask a woman out on a date, they're going to get rejected, right? That's their expectation. That's their assumption. Or in other words, that's their intermediate belief as it relates to that core belief, or those core beliefs of unlovability and being unattractive. So this may have an influence on this client's everyday life, but what we're going to see it the most is when a situation arises that combines that intermediate belief. So say this client is at a social function where it would normally be appropriate to say ask somebody out on a date, or at least start a conversation to get to know somebody, and a female that the client is attracted to, say, is introduced to the client by a friend. So that's the situation. That's a stressor for the client. Based on the client's intermediate beliefs that I've described, you can see how that would be a stressful situation. So we believe that the combination of that situation, right, being introduced to a woman, and the belief that the client has that they're unattractive, that the client's unattractive and the client's unlovable, this creates an automatic thought. Right? So you can see here it's the combination of the intermediate belief and the situation that leads to what we call automatic thoughts. Now in this case, the automatic thought might be something like, I need to get out of this situation because I'm going to be rejected. Or this is just going to result in embarrassment, right? This introduction and potentially setting up this date or getting to know this person, this is going to lead to embarrassment, right? So that's the automatic thought. So what are automatic thoughts? Well, automatic thoughts are thoughts that occur, as you might imagine, automatically. They're common to all people. Again, most automatic thoughts are useful and necessary to function within normal limits. These automatic thoughts, for most people in most situations, lie just outside of conscious awareness. All right? They can be thoughts, like spelled out in English, for example, or images. Usually a client will recognize the emotion before they'll recognize an automatic thought. So keep this in mind when we're working with clients, helping them to identify automatic thoughts. A lot of times they're going to be able to recognize that emotion before the thought. Almost all automatic thoughts that lead to symptoms are negative. And sometimes automatic thoughts are distorted. However, sometimes they are accurate, but the conclusion drawn from the thought is distorted. So now let's take a look at what happens after an automatic thought occurs. It leads to a reaction. And in the example that I'm using for this video of the male client that has feelings of unlovability, if the automatic thought is, if I stay here I'm going to be embarrassed, the reaction, which can be affective, behavioral, or a physiological response, the reaction might be embarrassment, anxiety. The behavior might be leaving the room, leaving the social situation that I was describing. The physiological response might be increased heart rate, maybe some trembling, headache, sweating. There's a wide range of possible physiological responses and affective and behavioral responses. So sometimes if we can't quite piece together the or any of these elements in the diagram so far, we can try to solve the equation kind of like an algebra. Like if we're missing the automatic thought, but we know the situation and the belief, or most of the intermediate beliefs, and we know the reaction, sometimes we can figure out the automatic thought. Oftentimes identifying the automatic thought is a substantial challenge in cognitive therapy, and it's it consumes a lot of the time relative to some of the other functions that we use, other techniques that we use in cognitive therapy. So this is the cognitive model so far, and you can see that this explains how symptoms become symptoms, right? But it doesn't really explain what we do, right? So this last piece of the model is the adaptive response. So you've probably read or seen information on like thought stopping and things of this nature, where cognitive therapists will suggest that the appropriate technique is to try to stop an automatic thought directly. I have not found this to be a very successful route, right? And it's paradoxical, in my opinion, to when you contemplate thought stopping, right? So if you have a particular object and you tell a client, don't think of that object. Let's say it's a red car. Like, don't think of a red car for 1 minute. Well, in order not to think of it, they have to think about not thinking about it. So really, you can see thought stopping logically doesn't make a terrible amount of sense. Although some clinicians have had success with it. Distractions, help teach the client how to distract themselves, which is, in a way, it's like interrupting the automatic thought with another thought. It's not really thought stopping. And the adaptive response is, or self-talk, right, is my favorite technique for disrupting the cognitive model running its course to a negative reaction, right, to an affective or behavioral or physiological response that's undesirable to the client. And with the adaptive response, it's based on the idea that we can consciously think thoughts, right? So we can use our brains to deploy a thought, to think a thought at will, right? So what the adaptive response is a counter to an automatic thought. It's not an attempt to distract. It's not an attempt to stop the thought. It actually fully acknowledges the automatic thought, but then it disputes it, right? As Ellis would say, it disputes it. So the self-talk or the adaptive response is rehearsed between you as the clinician and the client, and they are agreed upon. The solutions are co-created between the clinician and the client, and they're not always brief. Sometimes an adaptive response could be like an entire paragraph that the client writes down and memorizes. And when the automatic thought comes up, and in this case, this situation is going to lead to embarrassment, right? The example I'm using. The adaptive response could be something to the effect of, yes, this thought or this situation could be embarrassing, but that's the worst that could happen. That's likely the worst that can happen. And there's a lot of potential benefit to sticking out and remaining with this uncomfortable feeling, right? It's an adaptive response. So as the client applies the adaptive response, it results in a change eventually. As they repeatedly apply the adaptive response, it results in a change in the reaction. It doesn't happen the first time a client, typically the first time a client applies the self-talk. It took a while for the, chances are, it took a while for the automatic thought to form, like for all these pieces to come together, for the automatic thought to form when the belief meets the situation, and it's going to take a while to have change by applying self-talk. Not terribly long, but it will take a little while. So let's take a look at the cognitive model now, simplified a little bit, but with the adaptive response kind of plugged into the equation. So when we looked up here at just the cognitive model, you see this is, just explains why symptoms occur. But this model shows the cognitive model interrupted by the adaptive response. So what we have here is we have the core beliefs, right? We believe that these give rise to intermediate beliefs, which are more, the core beliefs are down deep, the intermediate beliefs are a little closer to the surface. These combine with situations that results in automatic thoughts, and then you have the adaptive response. So instead of going right to the reaction, the new reaction, I guess you could say, is the client's going to apply that self-talk. And sometimes clients are successful at applying the adaptive response, and sometimes they're not successful, right? And that's okay. There's going to be times when it's very difficult to apply the adaptive response, but I would encourage you as a clinician, as a counselor, to continue to support your client and focus on the successes. It takes a little while to learn these techniques. It takes a little while to execute them effectively. There's likely going to be occasions where clients don't successfully apply the adaptive response or don't apply it in a way that appears useful. But there will also be occasions, likely, where they do. And as this occurs, as the adaptive response is successfully applied, it results in a change. That's why I have the delta symbol in there, the triangle. It results in a change in the reaction, right? So it in a sense, corrects the symptoms that were the focus of treatment at the onset. But what it also does eventually is changes the intermediate beliefs and the core beliefs. You can see I have the arrows there, with the delta symbol pointing toward intermediate beliefs and toward the core beliefs. So this battle against the automatic thoughts is very much at the surface level, right at the thinking level. But as the client starts to win the battle against the automatic thoughts, the change occurs at deeper levels. It moves to the intermediate beliefs and eventually to the core beliefs. And what this does is it stops the automatic thoughts from occurring. So, as I discussed before, there's no real way to directly stop automatic thoughts, but there is a way to stop them. And it's this indirect method where the client's consciously thinking a pre-planned thought, an adaptive response, and applying it in situations they recognize. And these are all techniques that you will review with your client, help them identify automatic thoughts, help them to know when to apply the adaptive response, and then help them to accurately evaluate what happened, including the times when the adaptive response worked well, and then sometimes where it didn't work as well. And you make changes to the adaptive response. You fine-tune it so that it becomes the most appropriate that you can make it, and the most helpful for your client. And you might have a client that has several different core beliefs. I gave you the one example of a male client that is afraid of rejection, right? But there's many different core beliefs. Some clients have multiple core beliefs that are negative, right, or less than useful. And you might generate many adaptive responses for many different situations that could occur. So I hope this explanation of the cognitive model is helpful. As always, if you have any questions or concerns, feel free to contact me and I'll be happy to help you.